Good afternoon, everyone, and thank you so much for joining us today for our webinar on visual diagnosis with a focus on step one and level one. My name is Moses Murdoch. I am a resident in internal medicine. I have also been a tutor with Med School Tutors for a number of years, helping folks with these very exams. And I'm so lucky to be joined on this platform by the one and only Joe Hansen. Joe, could you introduce yourself?
Sure. My name is Joe Hansen. I've been working with Med School Tutors as an individual board tutor for pretty much everything in med school for the last 4 or so years. And the experience I'll bring to the table tonight is that I've worked with several hundred medical students preparing for their board exams in every medical school, with over 6,000 hours on camera like this, working with med students towards board style questions like the material we'll be discussing this evening.
Amazing. Joe is an all-star. You all are in for a treat. Before we jump into the meat of the presentation, I just briefly want to tell you a little bit about MSD and what we're about. We are a collection of folks just like you who are on the path of medicine in all its diverse flavors, all the way from med students who have done exceptionally well on the boards, through interns, residents, even attendings, who really bring a wealth of knowledge. And the focus is on one-on-one personalized tutoring, as well as advising on the various major steps that occur during medical training. I'll keep it there, but I'll tell you that all of our folks really love what we do. We're excited to work with folks and really bring that personalized touch. We'll talk a little bit more about MSD and the ways in which we might be able to help you at the end of the webinar. But without much further ado, I wanted to jump right into talking about what we'll cover today. So as the title suggests, we're going to give some general tips for approaching the imaging and other multimedia that comes along with USMLE and level one questions. We'll go over 10 or so high-yield images, and we hope that these will serve you well on the exam itself, but also give you an approach for thinking about how to incorporate the images that you're likely to see on test day with the vignette to give you the highest score that you possibly can get. We'll go over high yield pearls about the diseases and other entities along the way as well. And like I said, we'll have opportunities to answer any of your questions, both via a live Q&A at the end of the session, but at the bottom of the slide, you'll also note the various ways in which you might get in contact with us. We strongly encourage it, especially if there's a particular personalized situation that you'd like to talk through with someone. That is what we're here for. Along the way, the chat is where we'd love to get your participation. You won't be able to see the comments made by your co-attendees, but we will be able to see them. We'll address them out loud as much as we can, but we'll also address them in the chat. So if you see Joe or I looking off to the side, we're not texting our friends. We're responding to some of your co-attendees in the chat, really hoping to give you as much knowledge as possible for this Q&A. And with that, I turn it over to Joe just to go over some of the general tips when it comes to images and these exams.
Absolutely. So the types of images that you're going to see on kind of board exams, step one specifically, are going to be based on histology, which are usually very intimidating, gross pathology, which at least we can kind of get a better sense of what we're looking at usually, and then radiology, which seems a little bit unfair since we haven't really had the clinical grounding when we're getting to step one towards what we're supposed to be looking for on those images. And so tonight, what we're going to mainly be focusing is on how to anchor ourselves when we're looking at these pictures. What are we looking for? Generally speaking, how can we approach these things? There are other things on the exam that will involve multimedia. There will be audio files for auscultation of the heart. There will be occasionally some videos that kind of insert themselves into there that you have like a 5-second clip to watch or something along those lines. Those won't be our focus tonight. We'll be static images mainly this evening to kind of give you a sense of the bread and butter of what's typically going to show up on the exam. And one thing we really want to emphasize is that, as I mentioned, some of this stuff you haven't really seen in the clinical context. You haven't really gotten the language down because you haven't had the opportunity to see real patients with a chest x-ray or CT scan or a biopsy sample that's into pathology. As a result, it can be really intimidating looking at some of these pictures. You might feel like I have no idea what I'm looking at in some cases, but we really want to emphasize that if you feel that way, many other people probably feel that way while taking the exam as well. And Moses and I probably felt that way when we saw pictures like that when we were preparing for step one. So try not to get too intimidated by some of the images that we're looking at here. Really going to encourage you guys to try to speak up in the chat box tonight as we're looking at some of these pictures. Just shout out whatever comes to mind. There's really no wrong answers per se, and we'll kind of guide you towards the more right answers as we go here. Now, as far as the things that we're going to look for in the images themselves, the thing I want to emphasize most of all here is that we're doing an image-based kind of tutorial this evening, but the questions that you're going to do on the board exams are going to give you a clinical vignette. And in many cases, the clinical vignette contains pretty much all of the information you need to get close to a diagnosis or to create at least a very tight differential. The images then usually help you to select your best diagnosis or help to confirm the diagnosis that you've already come up with. Say, for instance, you have somebody coming in with the clinical signs of a heart attack and they give you an EKG, you might be thinking, well, I'm looking for ST elevations in this EKG, as opposed to jumping into the EKG just totally blank, saying, what am I looking for here? That being said, we're going to try to give you the tools that you would need to read these images cold, even though that's doing it the hard way. And on the exam, if you already have those skills, it should be even easier to piece together the image with the clinical vignette. It's important to point out that the pictures on the exam are bread and butter, pathognomonic, straightforward, here it is. And they're not usually forcing you to do anything complicated or to look into the marginalia of the picture. Usually right in the center of the photo, they're going to give you something that's super high yield. If we don't recognize it, that's okay. We can still figure out what's going on with the clinical vignette in many cases. For that reason, we want you to not panic if you look at something and we're not certain what we're looking at. That's okay. We can reason our way through it. And again, the vignette really gives you all the information you need to know on a board style question. The pictures we're going through tonight are kind of the icing on the cake. And if we have that icing on the cake, sometimes it makes the questions even easier, but that doesn't necessarily mean that you need to be able to diagnose these things point blank to do well on the exam, though it's not a bad idea to practice with them. Importantly, we don't have to know everything that we see in these pictures. If we see a pathognomonic finding, a high yield thing, but we don't really recognize what else is going on in the photo, or we don't know like where this biopsy came from or what else is going on in the CT scan, that's okay. You're not an expert yet. You're not a pathologist. You're not a radiologist. You're giving the basic answer to a basic question, looking at something that's super high yield that a general practitioner should recognize is basically the kind of criteria they're setting forth in these images. So try to keep it simple as much as possible. Anything to add to that, Moses, in terms of kind of general guide points before we go into this?
No, I think all of that was really beautifully said. The images help you test your hypotheses. You're developing, based on the vignette, an idea of what the pathology is. You use the images to confirm that. And then you really need to go to the second or third order reasoning, often digging deep into the basic science based on what you're seeing on those images, and will help you do that by providing images and then prompting you to really be active in the chat to get at some of those second order questions. And really in that spirit, we can jump right into the first image that we have for you here today. And just like Joe was saying, active learning is where the long-term memory really sticks in. So please, in the chat, what are we looking at here? What is the name for this dermatologic finding? I'm seeing a couple of great answers in the chat already. And this is, in fact, erythema nodosum. These names, it's like a salad of different archaic terms. Erythema red, nodosum, like a nodule of some sort, classically on the anterior shins. And you'll notice here in all caps here, this is an inflammatory reaction of the subcutaneous fat. It's a paniculitis. And this is where we're going to be digging into the second order questions here. What kinds of diseases are associated with the finding of erythema nodosum? And there are a couple of different diseases. So throw it out in the chat. What diseases do we see erythema nodosum in? And I'm already seeing a couple of great answers. Sarcoidosis, we're seeing IBD, we're seeing some of the endemic fungi. Folks are putting cocci in the chat. All of these are absolutely correct. Histo, another endemic fungus. Perfect. The way I remember this is that often we're looking at diseases that form granulomas, right? And so you can see granulomas under a microscope, but you can also see this inflammatory paniculitis sort of reaction in the skin that can be a big clue to the diagnosis. And of course, if this was an actual vignette on sarcoid, they might ask you about the basic science of the hypercalcemia that comes with sarcoid, or they might ask about, the regionality of some of these endemic fungi. This would help you get to that sort of a diagnosis. Anything to add on erythema nodosa?
Excellently said. I think that the only thing I would add is that while there is a large differential that can be associated with erythema nodosum, I would argue that the vast majority of questions in step one would probably focus on the sarcoidosis connection, maybe inflammatory bowel disease. It would be a stretch to see that we would end up seeing like tuberculosis or any of kind of the endemic fungi showing up with any reliability on the test. And so we would then lean on the vignette to kind of figure out what the underlying disease is. And if they give you the stereotypical 30-year-old African-American female, we would say probably sarcoidosis in that case. If they told you 16-year-old Caucasian female, I think inflammatory bowel disease in that case, simply based on what you would likely see in those age groups. But then we can also look for other clinical findings that would point us in the right direction. So the image tells us kind of the spectrum of stuff that we could be looking at, but the vignette will help us to nail down the specific diagnosis. So great job to everybody for chatting in the answers that we really appreciate. So keep that up as we move in to take a look at some other problems here.
Beautiful.
All right, so I'm up. We're going to be taking a look at this a CT scan of the abdomen here. Now, I want to point out, just jumping into this, how do I know this is a CT scan? The easiest thing that you can do as a step one preparing student is to look at the bones. I can see a vertebrae down at the bottom of the image. I can see some ribs poking out there. Those are bones that are bright white on here, and we know that CT scans are going to have bright white bones because CT scans are just a bunch of X-rays, and X-rays are going to reflect off bones, and we know that because at the very least we know what an X-ray of the chest looks like, where all the bones show bright white on there. If I were looking at an MRI or some other type of radiology, I might not see bright white bones specifically. So we see bright white bones in this image, we see very dense bones essentially, and so as a result we'd say we're looking at a CT scan. Then we have to orient where we are. And I can see that for the most part, I'm seeing a big old solid gray thing in the middle of the image here. And then also another solid gray thing on kind of the right side of the image, the patient's left side, which would indicate that we have some solid organs here, which means we're not in the lungs, so we're lower than that. So we must be in the abdomen. And so we've already got some people putting in some answers here, but can anybody tell me what the big organ that's dominating most of this screen is in this case to kind of orient our location? All right, cool. Got a couple good answers here. Waiting for a couple more to pop in. Make sure everybody's like playing along. Awesome. So everybody's saying liver. We're looking at our liver here. Now I'll point out, typically the liver isn't going to take up the entire space of the abdomen, so it looks pretty big in this case. And more importantly, the liver should be a very solid organ. And as a result, when we look at the liver in CT scan, we should expect relative uniformity throughout the liver. It should all be more or less the same kind of color of gray. As I'm looking at it here, I don't really see that. I see several splotches of what we might call hypodensities here on the liver. And so now the question would become, why would I have several different areas of different densities in the liver kind of disseminated all throughout? So what's the most likely diagnosis that's happening in this patient? Go ahead and give me an answer in the chat here. Got a couple of people answering already. And that's correct for the people who have answered so far. We're looking at liver mets. So these are liver metastases most likely. Now, can anybody tell me, the question on the screen, where do these metastases likely come from? This is a clinical question. We can't really answer it based on the image anymore. Now we have to kind of use our background knowledge. All right, lots of good answers here. Everybody's saying colon. That's correct, because the portal venous blood leaving the intestines has to go through the liver. If there is hematogenous spread of colon cancer, the liver is the big filter that catches all that cancer. Now we know this isn't a primary disease of the liver, because if you were to have multiple different tumors at different locations in the liver, that would just really be very unlucky. It'd be like being struck by lightning 17 times at once. Once is enough. We'd assume there's a primary source for the cancer that is then spreading to all of these different territories in the liver in this case. So while colon is the most likely answer here, given that colon cancers are relatively frequent and all colon hematogenous spread would go to the liver, keep in mind there are other organs, the pancreas as well as the stomach, that are also going to feed into the portal circulation and potentially spread cancers to the liver as well. There's a nice little mnemonic we have here. Cancer sometimes penetrates benign liver for colon, stomach, pancreas, and then breast and lung, which wouldn't be spreading via kind of like the portal venous system in that case. It would be more of a generalized hematogenous spread that would land in the liver in that case. Awesome. One question I've got from a student here is, how would we rule out cysts in this case? That's a good question. Generally speaking, if we were looking at cysts, we would probably anticipate that in that case, we would end up seeing different densities for each of these different lesions rather than kind of a uniformity to each kind of like coloration change that we're seeing there. Also, cysts may have bleeding involved, and bleeding can end up showing up a little bit brighter on the image because blood has iron in it, which will refract the x-rays that we're looking at. So generally speaking, I would probably expect more uniformity to a cyst, more of a spherical shape, maybe different colorations to the cysts on the image. And then most likely you wouldn't get kind of this degree of hepatomegaly here. All right. So with all that being said, anything to add, Moses, to what we said here?
No, that was beautifully explained. I was just typing in the chat for some of the participants, just pointing out that, and this is an advanced concept, like just like you were saying, various kinds of imaging, like arterially enhancing versus venously enhancing, can help tell the difference between infection and a cancer. But again, the vignette will help you because you will get features. It may be age, it may be cirrhosis. Notice that the liver, there's a little bit of nodularity going on in this liver. If this was a primary liver cancer, that might be a clue that you're dealing with cancer more than infection in the background of cirrhosis. Big picture, use the vignette to your advantage, as well as clues from the imaging itself. Cool. And here we just have a comparison. No, you're nailing it. We were just foreshadowing ourselves a little bit by talking about the smoothness of the liver, the homogeneity of its appearance, and I don't know if this is a contrasted image, but that can also help tell the difference in sort of advanced situations. Awesome.
All right.
Moving on to our next image, I really love what Joe did for us in the last question, which was orientation. What are we even looking at? And this might sound silly, you know, for some folks, it might be obvious that we're looking at a peripheral smear, but sometimes if you're stuck, just saying to yourself, what am I looking at? And progressively asking yourself that question over and over can help you unpack knowledge that you didn't know you had. So we're starting off with a peripheral smear. Let's take it one step further. What cell type are we looking at in this peripheral smear? Go ahead and throw that into the chat. And we have already some folks correctly pointing out that we're dealing with erythrocytes. We're dealing with red blood cells. And when you're looking at red blood cells, you're looking at the number of red blood cells, getting a sense of anemia. You're taking a look at the shape of the red blood cell. Is it the shape that we would expect? Is the central pallor the normal sort of central pallor that we would expect? Are there any inclusions? These are all things that you can find abnormalities in. But in this case, it's the way that the red blood cells are sort of arranged next to each other. I'm already seeing a few folks in the chat pointing this out. What's the name for this pattern of red blood cells? Don't be shy. Yes. Few folks have pointed out that this is a rouleau formation. And again, we're going to try to activate that second and third order thinking. What disease is associated with rouleau formation? And we already have someone so quick out the gate giving us a correct answer. Going to wait for a few more folks. And absolutely, this is classically associated with multiple myeloma. Overwhelmingly on the exam, if you see this, it will be multiple myeloma. And what it is actually shown on the screen already. It's essentially stacked red blood cells. And the question for you in the chat is, why are the cells stacked this way? What's the explanation for why in multiple myeloma you see this pattern? Go ahead and put that in the chat.
This is a tougher question. This is not a one-word answer.
Exactly.
In this case.
And I'll take the one answer that I see coming up in the chat. You all are so good. When you have an increase in the serum proteins, a monoclonal M spike, right? That changes the electrostatic relationships between the different cell surface proteins on the red cells that interact with that changed electrostatic space, and the red cells tend to stack on each other in the rouleau sort of formation. Beautiful. Awesome. Anything to add, Joe?
I'll point out that a couple students had asked in the chat about the possibility of spherocytes here, since if you're looking at the stacked red blood cells, they seem to have lost their central pallor. We're not really seeing like the normal biconcave disc shape. And if you had seen red blood cells that were floating off on their own that had that kind of uniform opacity, that kind of like lack of central pallor, I would normally say that spherocytosis, whether hereditary spherocytosis or autoimmune hemoleucemia, whatever's causing spherocytosis, might be the best answer. Let me pose this. If you run into a situation like this where you're like, I know that lack of central pallor is spherocytes, but I also am seeing the red blood cells stacked like poker chips here. If it is spherocytosis, we're really ignoring the stacking portion entirely, right? If we were to say that I think that this is spherocytosis because of the lack of central pallor, I still really haven't explained one of the main things in the dead center of the image, which is stacked up red blood cells. And so for that reason, that might dissuade us from jumping immediately to a conclusion based on our initial gut instinct here, because it doesn't adequately encompass all of the high yield components that we're looking at in the image. And so much like a vignette where you've highlighted like say a patient's age or clinical information, if there's an answer choice that doesn't agree or shake hands with the things that you've identified as being important, expanding your search is usually going to be necessary. So the answer to why not spherocytosis here is because it lacks the explanatory power to tell us why we have the stacking happening as well. Cool. I think we're ready to jump into our next example here.
And this is just a comparison with normal RBCs. Just one quick thing. Notice that when the red blood cells stack, this is a 2D projection of a very thin 3D sort of space where the red blood cells are floating. And if the red blood cells are on top of each other, one red blood cell is sort of covering up and occluding the pallor of an adjacent red blood cell. So that may be, it may be giving you a pseudo spherocyte sort of appearance, which would explain why some of these red blood cells are lacking that central pallor. But I agree. This is a niche point that is not going to show up on step one, but a great question nonetheless.
All right. So like Moses had mentioned in the previous question, even when we have a peripheral smear, we got to orient ourselves and say, what are we looking at? And here, it's pretty similar to the image that we saw before insofar as we're looking at a peripheral smear of blood. Now, everybody's going to be chomping at the bit to try to answer this question really quickly. It's got an answer right in front of us. There's a very high yield thing in the center of the image. But I'm going to ask this. What is in this picture? What is in this picture too many times that should not be in this picture so much in this image? All right, got one good answer. Somebody read, oh, a lot of people reading my mind here. I asked a kind of awkward question and people are answering it very well. So people are saying we're seeing lymphocytes and or specifically blasts. How do we know that we're looking at blasts? What are blasts? Blasts are very immature white blood cells, and immature white blood cells are unique compared to mature white blood cells insofar as they have a high nuclear to cytoplasmic ratio. The nucleus takes up the vast majority of the space inside the cell in very immature white blood cells. Typically, seeing a blast on a peripheral smear is fairly atypical. Seeing more than one blast on a peripheral smear means basically that we have leukemia at this point. It's more or less diagnostic of that. And so when we're looking at this image, we can say, oh, this probably looks like leukemia. But people are already typing in chat, so keep it going. What is the particular type of leukemia that we're looking at here? What is the pathognomonic finding that we can see in this image that tells us that? All right, everybody was ready to go on this one. I'm seeing lots of people saying that we see hour rods, which are these kind of fine crystals that are in the cytoplasm that we're seeing there in these blast cells. And specifically, hour rods are associated with some form of AML or APML. So excellent job, everybody diagnosing acute myelogenous leukemia here. Now, as soon as we see that, though, we know the questions that are going to be coming our way on the actual question on the exam. We're going to be asking about translocations and treatments and things like that. So what is the translocation that is commonly associated with APML specifically? All right, already got a couple good answers in here. All right, everybody getting fancy, putting the whole T parentheses nomenclature here. Appreciate that. And so good answer, everybody who's answered so far. This is a 1517 translocation. And so unfortunately, along with CML and some of the lymphomas, we have to memorize the translocation that's happening here. And the translocation is very unique in this case because not all AML has the 1517 translocation. Only some subtypes do, which are usually called the acute promyelocytic leukemias. And when we have that subtype, there's a specific therapy that we can use that's very effective that would not work for other versions of non-translocated AML. What's the treatment we would use in the 1517 translocation specifically? Good. All right. I'm seeing lots of people use the, okay, good. Full names here. Excellent job, everybody. So all trans-retinoic acid, abbreviated ATRA, which is a derivative technically of vitamin A. So I'm going to give some credit to some students who said vitamin A derivatives there. So excellent. This is a very high yield diagnosis on the exam. It's very likely that you'll run into a question asking about AML. They really like to ask about our rods. So we have to have that one down and ready to recognize here. And this may be one of the key examples that we have on our kind of list for this evening, where you probably do need the image in order to create the diagnosis. They will likely give you a clinical vignette that will describe a leukemic patient, but they won't give you anything that necessarily tells you that it's specifically AML, apart from the presence of the hour rods. So we'll point out that there are circumstances like this where the image actually is necessary for the diagnosis, although it may not always be necessary and sufficient, meaning that we might need the vignette to kind of help us to get there as well. All right, ooh, good question popping into the chat here before I hand it back over to you, Moses. What symptoms would we get for leukemia? So I really like answering this question because it comports directly with the lab values. There's two ways they can ask you about leukemia. Number one, they could give you the laboratory values for the CBC. Leukemia means white blood cell cancer that's filling up the bone marrow, which means that we don't have any space in the bone marrow to produce red blood cells. We don't have any space to produce platelets. We might produce a lot of white blood cells, but they're all going to be blasts. They don't really do anything. They're not functional. And so what you're going to find in your CBC is most likely anemia, thrombocytopenia, and leukocytosis. Lots of white blood cells, albeit non-functional white blood cells. That combination is usually more or less pathognomonic with leukemia. How would they give you symptoms for that then? A person coming in with easy fatigability, anemia, as well as easy bruising, maybe some bleeding gums, something along those lines, thrombocytopenia, and repetitive infections requiring multiple doses or bouts or treatments with antibiotics in the last couple of months, and kind of relapsing fevers. Now, that doesn't mean that they have low white blood cells. It means they have low functional white blood cells. So they might have a high white blood cell count that is going to go along with multiple infections. So you can either see the clinical symptoms of anemia, thrombocytopenia, and bad white blood cells, or they could actually give you the CBC. Either way, we're ready to go. Now, we don't know it's AML, though, until we look at the picture. Anything to add to that, Moses?
Just very briefly, we'll note that in the absence of hour rods, it is impossible to know if you're dealing with a myeloblast or a lymphoblast purely from the image. Now, if you want to be a hemopathologist, you could possibly find some other clues. But for the purposes of step one, if you don't see hour rods, you don't actually know if you're dealing with lymphoblasts or myeloblasts, which means you don't actually know that purely from the image whether you're dealing with AML, myeloblastic leukemia, or ALL, lymphoblastic leukemia. Of course, you can see clues from demographics and other things that we don't really have time to get into. But I want to caution you from assuming one lineage or the other in the absence of something like flow cytometry that give you markers, or like hour rods, which would be strongly suggestive of a 1517 for exam purposes. Otherwise, beautiful description. AML is my research and sort of life interest, so I will restrain myself further and instead move on to the next image, which we're back to radiology. Makes some folks nervous, makes me nervous, but we'll tackle it one step at a time. We're looking at an image of the thorax, right? And it's important to have an organized approach to a film. That's more useful clinically. On the exam, you want to use it as a hypothesis testing tool. You can't be looking at every rib and trying to determine if there's a fracture or something like that, because you only have so much time to answer a question. But just to state this outright, there's the ABCDEs, and some people go to FGH of chest x-rays, right? You're looking at the airway, the bones, the cardiac silhouette. You're looking at the diaphragms. You're looking for effusions. You're looking at the lung fields, right? The gastric bubble, the hilum. And I'll actually pause at the hilum because what do you all see in this image? And I see one person already chiming in with a hilar opacity. Someone else talking about perihilar lymphadenopathy. Beautiful. This is hilar lymphadenopathy. You all are killing it in the chat. Thank you so much for participating. And this finding of hilar lymphadenopathy is strongly suggestive of a particular disease, especially if the demographics fit. And we'll do a little bit of a callback to an earlier image, just tying things together, spaced repetition here. And already in the chat, we're seeing some folks chiming in with some diseases. What disease is classically associated with hilar lymphadenopathy? We're seeing that absolutely sarcoidosis. You know, other folks are chiming in and saying that there's other granulomatous diseases, certainly. But I would say that if you see this on the exam with appropriate demographic features, this is going to be sarcoidosis, 1, 2, and 3. And we remind ourselves that this is an immune-mediated disease, really leading to non-casing granulomas, is what you'd see on pathology. Now, here is where I throw it back to the chat. What are some other laboratory findings that would be suggestive of sarcoidosis? There's a couple of them, so throw at anything you can remember. I'm seeing folks talk about hypercalcemia. We remind ourselves that granulomatous diseases, 1-alpha hydroxylase, ramps up calcium, so you can see hypercalcemia. Beautiful. And I'll just, in the interest of time, talk about the elevated ACE levels. Exams love to point to this because it's something that's associated with sarcoidosis. And I'll also point out that there are other features. That second bullet point, the erythema nodosum, we already saw as the first image in our slide deck. We talked about the granulomas, but really, sarcoid can be a systemic disease, and depending on where in the body it's affecting, that's where you'll see the manifestations, and the patients will tell you that they're having different symptoms. So neurological symptoms like Bell's palsy, they might have ophthalmologic issues like a uveitis. So diverse clinical presentations, but if you see that perihilar lymphadenopathy, you're on the right track to sarcoidosis, keeping in mind that rarely it can be associated with a few other things. Joe, anything to add on sarcoid or hilar lymphadenopathy?
No, I think you nailed it. Between our look at erythema nodosum and now sarcoidosis, I think we've nailed this autoimmune stuff that we're seeing here.
Awesome. And I'll just compare very briefly what a normal hilum looks like, just really to hammer this home. You can see on the left here, you don't see that opacification. You really see that hilar lymphadenopathy really prominently on the right. Excellent. Joe, take it away. This is a scary disease.
So once again, we have to orient ourselves as soon as we see this image. This is another CT scan that we're looking at. And once again, we know that because I can see the vertebral body as well as ribs emanating from that vertebral body that are bright white, which indicates most likely seeing bone there that's showing bright white, tells us that we're looking at CT scan with multiple different X-rays in order to generate it. Now, in this case, unlike the previous picture, we can see a big black space on this image with really nothing in it, which is going to be our lungs. Air does not reflect the X-rays at all and shows up black on this image. So bone is white, air is black, and those are two opposing colors that we're looking at. With everything else, soft tissue, fluid, blood, etc., having densities in between those two poles. So now we know we're in the chest. The thing that's in the center of our image is most likely some kind of cardiovascular structure. Now, depending on where the cut is for the CT scan, we could be at the level of like the aorta and pulmonary artery, or we could be at the level of the ventricles, just depending on how far down or up in terms of the CT image. In this case, what are the major structures seeing in the middle of this image? Are we looking at the heart or are we looking at blood vessel here? All right, got some good answers coming in terms of our orientation. We see mostly blood vessels, we see the aorta, and then in addition to the aorta, we see, as Moses is highlighting here, the kind of pant leg appearance of the bifurcation of the pulmonary artery. So we can see the aorta as a round structure and the pulmonary artery bifurcating in this case. Now, the one thing that we're usually looking for in this image is some kind of heterogeneity. We saw in the previous picture where we were looking at the liver that there were heterogeneous, weird-looking areas that weren't uniform. Here, we can see heterogeneity because as we look at the pulmonary artery, there's an area that's dark that's just kind of sitting in there like a little mustache, not really doing anything for us in terms of creating a bright color. So the question would be, why would this irregularity exist? There has to be something there that is different than the stuff around it. So what would be our diagnosis here? What are we looking at that doesn't seem to be as kind of bright or dense as what's in the pulmonary artery surrounding it? All right, excellent. Really distinct answers here. So this is most likely a pulmonary embolus, and specifically we might call this a saddle embolus insofar as it's sitting on top of the bifurcation of the pulmonary arteries, which is usually the bad kind of pulmonary embolus so far as it's very large and likely very symptomatic. So patients who are coming in with a pulmonary embolus most likely will describe sudden onset dyspnea, pleuritic chest pain. They'll be very tachypnic and also tachycardic, because this is going to form a type of shock. Now, I'm going to get kind of tricky before we take a look at the rest of the answers that I'm going to be asking here. What kind of shock? There's 4 different flavors of shock typically. What kind of shock are we going to see with a pulmonary embolus? Can everybody type into chat what you think this type of shock is? Okay, I'm getting multiple answers here, some dissension among the ranks of the students, but I've got a couple of people saying obstructive shock. So the 4 types of shock are cardiogenic, heart can't pump; hypovolemic, heart doesn't have anything to pump out in the first place; distributive shock, where we have all of our blood vessels opening during sepsis; and obstructive shock. Obstructive shock can mean either we're smashing the heart with like tamponade or pneumothorax, so the heart can't fill, which means it can't pump and our blood pressure goes down, or alternatively pulmonary embolus, where you're obstructing the inflow of blood into the left heart because we're blocking the outflow of the right ventricle. This would be a form of obstructive shock that we can end up seeing in these patients, which means they can present with very scary vital signs, very low blood pressure and tachycardia in some cases, and more severe pulmonary emboli. All right, and so if we wanted to proof positive diagnose this patient, what is the imaging test of choice for a pulmonary embolus? Can everybody try to give me an answer here as to how we would definitively prove this? I got 1 solid answer, so I'll take it. 2, 3. All right, so really specific answers here. CT angiography is usually our best answer here in order to read the blood the instructions that are in there. We can other scan, the VQ scan and things like that, but more commonly the test is going to be CT pulmonary angiography. Point out that other tests that are good for pulmonary embolus diagnosis, like the VQ perfusion scan, probably isn't going to be there in competition with CT angiography on the questions on the exam. You're never going to need between 2 things that are viable and good answers. You're likely going to have to choose a good answer from bad answers on the test. But if 2 things are competitive, that usually means they're not going to show up next to each other on the list of answer choices. Everybody's already started producing answers for this one, so I'll just jump ahead and say it. The EKG has a very specific set of findings called the S1Q3T3 abnormality, which we should probably just look at it because it's kind of hard to describe verbally. When we're looking at the multiple different leads in the heart, lead 1, which is the top lead there, is going to have a very pronounced S wave that's diving downward more than you would normally expect. And then in lead 3, we're going to see a very pronounced Q wave, which is the first part of the QRS complex, as well as inversion of the T waves. If you see this, this typically means we most likely have a pulmonary embolus that's developed, but this would be one of those specific and not super sensitive findings where you won't always end up seeing this show up, and specifically on the exam. They might not ever mention it for step 1, but if you catch it, you know what you're looking at. And it is first aid worthy, so we got to pay attention to it at least a little bit. All right, I think that kind of does it for our PE question. Moses, anything to add to that?
Totally agree. Let's move on to another imaging study. Same pattern here, again, orienting you to the location within the body. I love that description of the pant leg pulmonary artery here. Thankfully, in this patient, no embolism. But first of all, I'd like to ask the chat, I'm circling with my cursor, this structure here, what am I pointing to here? I already saw one correct answer. Right, we're looking at the aorta, right? The aorta has that arch, the ascending portion, and then loops back around, descending right next to the pulmonary artery. And as folks have already, y'all are so far ahead of me, you're already noting that there is, again, symmetry is, the natural state of the body. The aorta is not supposed to have this sort of darker left half and a lighter colored right half with a strip down the middle. And since folks have already jumped so nicely to the diagnosis, this is in fact an aortic dissection. Beautiful. And this can be life-threatening. On the exam, you're reading through the vignette, you get the age, the gender, and then the past medical history. What in the past medical history would put a patient at highest risk for an aortic dissection? Go ahead and put it in the chat. I'm already seeing one correct answer. Beautiful. As folks are pointing out, hypertension is huge. Remember, of course, that sort of more exotic and rarer connective tissue disorders like Marfan's can also predispose to that. And I'll also just say that the presentation is very classic. So the story that goes along with this image will be a big clue. Why? Because it's sudden onset, it's tearing, radiating to the back. You have those unequal blood pressure measurements, right? Because of this dissection that may be propagating, as well as stroke syndromes, or even myocardial infarction syndromes, if the dissection is bad enough. And this is a really beautiful image here of the dissection, but sometimes what you can see, and this is just the comparison of the normal aorta. Notice smaller in size, does not have the same sort of strip down the middle, and is homogeneous in its appearance. You can see this on a chest x-ray with a widened mediastinum. And so that's one clue that if you don't have the sort of gold standard imaging that would lead you to suspect, you might see that in a widened mediastinum. And of course, the widened mediastinum is a non-specific. It could be aortic injury. It could be a mediastinal mass. It's tough to say, but it should raise a red flag for something like a dissection if the rest of the story is suggestive. Joe, anything to add on the widened mediastinum front or on aortic dissection?
I think you nailed it. I think we're all set here.
Amazing. And just again, a comparison, normal on the left, abnormally wide mediastinum on the right. Moving on, what have we got here?
Okay, we got a 3 for 1 on this one, and we're going to orient ourselves once again by saying this time we're looking at the head, we're looking at the brain, and once again, we can use our criterion for determining that we're looking at a CT scan by noting that the skull is bright white on this image. So we have X-rays being reflected by the skull, which indicates this is a CT and not an MRI. Now, the thing is, we have a bunch of other stuff that's showing up bright white in each of these images as well. So apart from the skull, what else is very dense on this image, meaning that it shows up white on the image in each of these three? Okay, we got some direct answers that you guys are giving to the diagnoses here, which is great. We got to start out by saying, correct, we're looking at blood. Each of these images is showing some kind of intracranial bleed that's developing. A lot of students are already kind of giving their answers as to what each bleed is. So if you haven't given your answer yet, go ahead and pop it in the chat. Which bleed are we looking at in sequence for image 1, 2, and 3 here? And lots of students are nailing this. We can identify that we see an epidural hematoma on the left, which is usually noted by the fact that it's got a lens-shaped appearance, so kind of bulging into the brain there. Whereas in number 2, in the middle, we can see blood in kind of all the sulci of the brain in between the brain spaces, meaning the subarachnoid space is full of blood in this case. And then finally, on the right, we can see a crescentic hematoma that's developing in that case, which usually is going to be more associated with a subdural hematoma. So epidural, subarachnoid, subdural in that order. So we can identify these guys just based on their shapes and appearances here, keeping in mind that subarachnoid hemorrhage is the one that's not on the outside of the brain per se, but is kind of like in between all the nooks and crannies here, which puts it between the other two. So let's kind of talk more detail about each of these bleeds. So for a subarachnoid hemorrhage, the one with the blood in the middle of the brain, which blood vessels are usually the ones that are affected or the causative problems here? Any guesses what blood vessels I would blame here? All right, I've got a couple good answers here, a couple answers that are kind of associated with other diagnoses. these are usually going to be the arteries in the circle of Willis. So we're talking the big ones. We're talking like ACA, MCA, PCA. And specifically, what we're looking at here is that we have berry aneurysms that form on these big arteries. And these aneurysms, when they rupture, are going to end up causing bleeding in the space they travel in, which is the subarachnoid space. Generally, the aneurysms occur at branch points in the arteries. So the branch point between the ACA and the MCA, for instance, or the branch point at the anterior communicating artery and the ACA are examples of where we will commonly see aneurysms. And generally speaking, as people are pointing out, hypertension causes these things to explode. Now, we need to have an aneurysm in the first place, which in many cases is going to start due to something like autosomal dominant, polycystic kidney disease. So connective tissue injury is usually what causes the aneurysmal formation in the first place, and then hypertension causes the aneurysm to rupture. So can everybody tell me, what is the presentation? What will the patient say is happening to them when they come in to the emergency department? All right, got some good answers here. Either we're going to hear worst headache of my life, and we usually describe that as a thunderclap headache. So while you'd be unlikely for the patient to say thunderclap headache, we would describe it as a thunderclap headache, so I'll give you credit for saying that. So final question here, what is the medication we would use here? What class of medication we would use in a patient like this? All right, a lot of students have already answered this, so I'll kind of give you guys credit. Usually nimodipine is like the drug of choice, but it's usually calcium channel blockers in general. Want to clarify, these are not class 4 antiarrhythmics. That would be something like verapamil or diltiazem, which really don't have much of a blood vessel effect. We're looking for the dihydropyridine drugs. Nifedipine, nicardipine, amlodipine, anything that ends in dipine would be good. Nimodipine is the one that we prefer to use for the cranial blood vessels specifically. And the strange thing here is that I'm not really worried about the accumulation of blood in the cranium as causing a problem. I'm worried that the blood surrounding other nearby circle of Willis arteries is going to cause vasospasm in those arteries, which will then lead to ischemic lesions downstream. So I'm kind of worried about like secondary strokes happening here, which is kind of a surprising thing to think about. And usually nimodipine can help with that a little bit to prevent the development of those secondary strokes and vasospasms. So awesome job answering this stuff, guys. Let's bounce over to talking about the epidural hematomas now. So a couple of people already mentioned this artery before. There's one specific artery that's usually the cause of an epidural hematoma. What is that artery? Good, all right, good answers here. We've got the MMA, the middle meningeal artery, which is a branch of the maxillary artery, which means that we're looking at like the external carotid distribution here. And so there's a specific point on the cranium, on the skull, where we're going to end up seeing that the middle meningeal artery is very susceptible to laceration. What do we call that unique point on the skull? I got a couple good answers. So, I like temporoparietal region. That's a good answer. But the specific name that we have here is the pterion. The pterion is going to be the kind of like branching four corners territory where we have the parietal, temporal, sphenoid, and frontal bones all coming together. And in that particular spot, it just turns out the bone is very thin, and that's where you end up seeing the middle meningeal artery popping up. And so this is kind of like being struck by a flying object, a baseball, golf ball, things of those nature can end up causing direct injury and fracture here, to not to mention falls and general head trauma that strike the side of the head, and that can lead to the development of an epidural hematoma. Now, there is a way we describe the presentation here. The person will end up falling, getting up, and then falling again. What do we call that period between the two falls? Excellent. All right. Very detailed descriptions. Nice job, guys. This is the lucid interval. The initial head strike might cause a concussion and maybe some loss of consciousness due to direct brain trauma. As the blood begins to accumulate in the epidural space, the person wakes back up. They're conversing with you. As the pressure rises inside the cranium up to the point where we start to actually compress brain structures, the person then loses consciousness again due to elevated intracranial pressure. And so that lucid interval is actually a very dangerous thing because the mortality in epidural hematomas is quite high. If you get the patient to the hospital, if we put a burr hole in their skull, we can easily drain this blood and kind of get rid of the middle meningeal artery bleeding. But if we don't make it to the hospital, this is a life-threatening, possibly mortal condition. So very dangerous for patients who end up developing epidural hematoma without prompt medical evaluation, surgical management. All right, let's go ahead and bounce over to the last of the three. So again, yes, to the student who just answered, yes, you're correct. What is the blood vessel that's associated with a subdural hematoma? Good. It's when I say blood vessel, I'm kind of misleading a little bit. It is blood vessels. It is veins. The bridging veins that are going from the cortex up to the diurnal venous sinuses are going to be the ones affected. And generally speaking, the reason that this is going to happen is because the brain is going to have blood vessels kind of traversing the space between the brain and the skull in order to drain into these venous sinuses. And if the brain rocks around in there, we can stretch and snap these veins. So when we're looking at this, we can have an acute presentation where somebody falls and strikes their head. Usually we're looking at like more of a elderly patient or a baby in these cases, elderly patients for falls. And the other possibility is that we could have like relatively mild trauma in somebody repetitively, in somebody who has brain atrophy. This is like generally an alcoholic with repetitive subdurals, but you can also end up seeing this in somebody who has brain atrophy for other reasons like Alzheimer's and things of that nature. So generally speaking, we have the elderly patient as our normal kind of presentation here, but also alcoholic patients are very commonly going to have subdural hematomas. The important thing here about the subdural is that this one will cross suture lines, and that gives us that kind of crescentic shape that we're seeing there on the image. We don't see an epidural hematoma cover one whole hemisphere. We will see the subdural hematoma cross or do one full hemisphere. It will not cross hemispheres though, because we can't cross the dural sinuses. So you won't see the entire brain affected by this, but one whole side likely will be. All right. And let's see here. Anything else to add to that, Moses?
No, I think you already nailed the association here with this very sad situation of child abuse where you see the subdural hematomas. Just to add that you can see retinal hemorrhages, and this is referred to as the shaken baby syndrome. I just want to pause and have everyone do a round of applause for Joe. That was a tour de force of hematomas. Amazing job. With that, I think we can move on to chat about a couple more images. We're nearing the end. Thank you again so much for staying so engaged in the chat. Really appreciate it. Here we have a very classic image that we'll discuss. And so I'll just give you all a moment to take in this eye. And what is the name for the finding? I'm seeing folks talk about the disease already. Y'all are too good. Beautiful. I'm seeing a few folks already talking about Wilson's disease, and these are the Kaiser-Fleischer rings. So again, here you're correlating physical exam finding, in this case, the copper-colored ring around the eye, to a clinical presentation. So I'll throw it to the chat. Is this disease one that affects the elderly, 70s, 80s? Does it affect babies, in their the first decade of life, or are we talking about more middle-aged folks? Go ahead and put that in the chat. Amazing. So here we're talking about 30s, 40s, 50s, relatively young. And I always like to think of diseases as in buckets. So obviously we have eye involvement, ophthalmologic involvement. What other organs? Name another organ that is involved in Wilson's disease. Beautiful. So I'm seeing some folks mention the liver, right? The copper, which is at the core of the pathophysiology of disease, can lead to a cirrhosis type picture. It can lead to an hepatitis type picture. Could even lead to a liver failure sort of picture, but beautiful. And I'm seeing already in the chat, folks have already leapfrogged me and talking about a neuropsychiatric picture. So there can be gait disturbances, Parkinsonian sort of issues, but we're talking about young liver, and we're talking about neuropsychiatric. Wonderful. Now we get to what could be tested actually as the second order question here. Talk to me and put in the chat what gene, and if you're feeling fancy, what chromosome is affected in Wilson's disease. And I can't get one past you. Yes, this is ATB7B on chromosome 13. That's perfect. And then if they wanted to have more of a treatment spin to this, what treatment can be used for folks with Wilson's disease? And I'm seeing both the general term, which is chelation therapy, you want to get rid of that copper, and the more specific medication that is referenced in first aid, which is, of course, penicillamine. Wonderful. Wonderful. Anything to add here, Joe?
No, you nailed it. I'll just add there's a really good episode of Scrubs about this. So very educational television show, Scrubs. If you're going to watch anything, you want to learn something from it, it's that. Don't watch House or anything like that. Those are
You get it all here, folks. You get first aid pearls, and you get TV Rex.
That's right. That's my secondary specialty.
I love it. Okay, take it away.
Sure. So next one here, once again, we're looking at radiology and we're looking at an x-ray. Now, as we would usually do, as Moses had mentioned with the first chest x-ray we looked at, we're going to try to do kind of a heuristic approach here. Usually the approach is ABCD, which is looking at airway, we're looking at bones, cardiac structures, and then diaphragm. So being very organized, we look at the airway, which more or less looks centered here, slightly blurry image, but we can kind of see that there's no like tracheal deviation. If we're looking at our bones here, I can see the spine right behind the cardiac structures. I can count the ribs. I see there's no direct trauma to the ribs. I can see the clavicles. Those all look fine. And now see cardiac structures. And there's something weird going on here, which people have already started to notice. Can anybody who hasn't answered yet tell us, what are we seeing in terms of the problem or the kind of irregularity we're noticing with the cardiac structures in this case? And we have identified correctly that this is dextrocardia. The heart is pointing towards the patient's right. More to the point, we also see a gastric air bubble on the patient's right as well, which indicates it's not simply dextrocardia in an isolated sense, it's total situs inversus, which means everything is kind of flipped around. And some patients or some individuals have already noticed here that usually the kind of associated clinical syndrome with this is going to be Cartagener's or ciliary dyskinesia. And generally speaking, what we're going to find with this is multiple pulmonary infections that are going to be associated with the inability for cilia to clear the small airways, allowing for congestion, the development of stasis and infection. In addition to that, we can end up seeing infertility in some individuals who have Cartagener's as well. Now, the kind of following thing here is what specifically, when we're looking at the cilia, what specifically is going to be kind of mutated in this case to cause lack of functionality? All right, got a couple good answers so far. See if anybody else can throw in there. And we have a lot of people saying dynein, and that's correct. There's a problem with the dynein in this kind of ciliary arms that's preventing us from actually moving those cilia. All right, I want to answer a question a student had asked here about the air under the diaphragm here. The air of the diaphragm, which I made passing reference to, right underneath the cardiac apex is likely the stomach. There's usually going to be air under the patient's left hemidiaphragm where the gastric air bubble is located. In a typical patient, air under the right hemidiaphragm is very bad and usually indicates that there's air in the peritoneal space. But given that we have dextrocardia in this case, I'm willing to believe that the air that we're seeing there is most likely the stomach that is located on the incorrect side of the body. And I can kind of agree with that specifically because I don't see a gastric air bubble on the patient's left side where I'd expect to see it. So it stands to reason that likely is the stomach that we're seeing in there. You have a nice air fluid level with a solid line there because there's likely fluid and content in the stomach that's being dragged down by gravity, and air rises to go right underneath the diaphragm there. Great. Anything to add to that, Moses?
No, I'll tell you what I'm likely to tell my new interns coming up. NTA, nothing to add.
Very good. All right.
And we can move on to another image, close up of someone's hand, someone's finger. And this is a clue to a very common disease, high yield. What are we seeing in this image? Beautiful. I'm getting a lot of info in the chat. I'm getting other physical exam findings associated with disease. I'm getting the name of this particular finding as well as the disease itself. So you all are doing very well. These are splinter hemorrhage, nail bed hemorrhages, and they're associated with bacterial endocarditis. And there are a number of different features that go into a diagnosis of endocarditis, or at least are suggestive of endocarditis. In the chat, I'm just going to start calling out what folks are putting down because it's so good. Folks have mentioned Janeway lesions, right? And there's also the associated Osler nodes, which are painful. Folks are pointing out some of the eye issues, the Roth spots, perfect. And the fact that in certain populations, such as those who abuse IV drugs, you can have infective endocarditis of the tricuspid valve. And here I just have some images for you from first aid. Obviously, it's an infection involving the valve, so you can see fevers, you can see Roth spots, you can see Osler nodes, which are painful, Janeway lesions, which are classically not. You can see anemia. Think of it as anemia of chronic disease. We started out by giving you the clue that this was a nail bed hemorrhage or a splinter hemorrhage. And of course, you can have emboli flicking off of infected material, that vegetation that is attached to the valve that then gets flicked off. And unfortunately, that can lead to emboli to the lungs, a septic emboli to the lungs, septic emboli to the brain, as well as other parts of the body like kidneys, etc. Anything to add about endocarditis or any of these physical exam findings, Joe?
I suppose the only thing that I would add to this is that for questions that you're going to see on step 1 board exams, there are kind of a list of criteria that you need to make the diagnosis of infective endocarditis. We can use the Jones criteria that's for rheumatic fever, but we can use the Duke criteria for this stuff. And so the idea here is that there are a bunch of different individual criteria that line up to form the diagnosis of infective endocarditis. And usually they say we need like 2 major or 1 major and 3 minor or something along those lines when you're looking at like one of the major textbooks here telling us how we're supposed to diagnose this stuff. For the purposes of step 1, if you see some major findings, you're likely looking at that diagnosis. I don't think that we necessarily need to get too detailed. While you need to know this stuff clinically, you might be asked about this while you're on the wards in order to actually diagnose a patient. Generally speaking, if you see that you have Janeway lesions or you recognize that in an image, that probably is infective endocarditis, even though we don't necessarily in the image have everything that we would need to officially make the diagnosis. So generally speaking, the images can point us in a direction, and we can usually go with the most likely diagnosis in these cases rather than following a strict list of clinical criteria. In case anybody's worried about memorizing several different lists, there's enough to memorize already. We don't necessarily need to memorize like all of the specific criteria for diagnosis here.
Beautifully said. Beautifully said. Two major or 1 major and a couple minor or all 5 minor. That's why we have MD Calc. Not something you need to memorize for step 1.
Exactly. All right. So for our next picture here, I do want to point out that when we get an image like this, usually if you were to get this type of image in the hospital, as a pathologist, if somebody were to send this to you, you would send them a note back and say tissue of origin or some kind of question mark to them to say, where did you get this? Because we don't know what we're looking at unless we're told the clinical background for the patient. So I will supply that we are looking at a lymph node biopsy in this case. With that in mind, can anybody tell me what specifically this diagnosis probably is, just on the basis that I'm doing a lymph node biopsy here? Wow, we got some all-stars already putting the correct answer in the chat box here. All right, so we've got some people saying lymphoma. Specifically, the type of lymphoma we're looking at here is not Hodgkin's lymphoma. Hodgkin's lymphoma always has Reed-Sternberg cells, which is kind of the owl eye picture. We don't see that here, so we're going to say Burkitt lymphoma. And the reason we're saying Burkitt lymphoma is because of the starry sky appearance that we're going to end up getting here, which is a bunch of lymphocytes with some interspersed macrophages. And that kind of creates kind of like what looks like a bunch of constellations in the sky if you really squint your eyes at it. Generally speaking, this is the type of lymphoma that's most commonly associated with Epstein-Barr virus. I will point out, however, that Epstein-Barr virus more commonly is going to cause nasopharyngeal carcinoma if it's going to cause cancer in the first place. But they still love to ask, if it is lymphoma, which one is caused by EBV, and it's Burkitt's lymphoma. Now, specifically, there's a couple key clinical findings that we can get here. And if we were looking at the endemic form of Burkitt's lymphoma that's found in certain sub-Saharan African territories, what would be the major clinical finding that you would see in addition to large lymph nodes in this case? Can anybody tell me in the chat what you'd see in like the African variant that we have here for Burkitt's lymphoma? Got one solid answer here. See if we can get a couple more. Good, excellent. All right, lots of people. Jaw tumor, we usually see a facial lesion in individuals who have this, usually even at a very young age. There's a very clear picture and first aid of this to go refer to here for the type of lesion that we see with Burkitt's lymphoma. And the question they're always going to be asking, and some people have already answered this, what translocation are we going to see here for Burkitt's lymphoma? All right, got a couple people already putting the correct answer here. Specifically, we're going to see an 814 translocation. Now, here's a trick for those who didn't necessarily choose 814 as their answer here. Every lymphoma that we're going to pay attention to is going to have a 14 in the translocation, because chromosome 14 is where we have the heavy chain for immunoglobulins. And generally speaking, cells in the lymph nodes, B cells, have the job of producing antibodies, which means they're always going to be turning on the territory of chromosome 14 that makes antibodies, which means if you slot in a different protein into that territory on chromosome 14, like c-Myc, for instance, then we're going to end up producing that as the cell's job. And if we're doing that with c-Myc, which is a transcription factor, or we're doing it with BCL2, which is an anti-apoptotic factor, if we're doing a cyclin D1, which is a cell cycle regulator, we end up developing either immortality of the cell, rapid duplication of the cell, something along those lines, which are going to lead to the development of cancer unregulated cell growth. So when they ask you translocation here, usually some kind of 14 translocation for lymphomas. And one thing that was told to me by another tutor is that the 8 in 814 looks like a B. So Burkitt's lymphoma is the one that is 814 specifically. I'm not sure if that was you, Moses, that told me that, but like that stuck with me. It works. Cool. So Moses, anything to add about Burkitt's lymphoma here?
No, I think you really nailed it. It's tough to keep track all of these translocations. I think that comment about the IGH is super, super key. There's maybe one lymphoma that doesn't have it, right? But it was one of those things where you memorize the tingible body macrophages are the stars, right? And the background of hyperproliferative B cells is the sky. That dark blue represents the sky. And that's in contrast, I will say, to something like Hodgkin's lymphoma, where we know that the actual cancer cell, the Reed-Sternberg cell, is the minority of the cellularity of a particular lymph node mass, in contrast to Burkitt's, where you really have out of control proliferation of the B cells. With that, I really want to thank all of you for hanging with us, for participating in the chat. You've already sort of heard my spiel on Med School Tutors. The only addition I would have here is that medicine is a long path. You don't have to walk that path alone. We are here really at every stage of training to answer questions, provide advising, help you with schedules, provide whether you need a drill sergeant or you need a cheerleader. We're here to help you with whatever it is that you need to achieve your goals. I mean, since I've already talked a little bit about this, Joe, is there anything else that you feel it's important for the participants to know about MST before we launch into our Q&A session to round out today's webinar?
Yeah, sure. I'll simply point out that our role here when we're working with medical students is to act as a mentor. And as a result, we can kind of help in really any fashion that you might seek help while working through medical school material. We're kind of like a one-stop shop for anything from the MCAT, which hopefully everybody has gone through at this point, all the way up through applying to residency and then kind of doing board exams even beyond that once students are in residency doing step 3 and beyond. And so as a result, we do develop longitudinal relationships with students. And even for those whom I'm not actively tutoring at the moment, I still keep tabs on a bunch of students that I've worked with for the last couple of years. And I really do like hearing back from them when they make, major goal progressions, like matching to residency and things along those lines. But I'm also here to provide them advice and recommendations for things that they're working on, like shelf exam, step 2, things like that, even if we're not actively working together. So we're here to kind of form relationships and bonds with students that we're working with. And it is sometimes really nice to have somebody in your corner that can provide unbiased advice in terms of like what the best next step is for you, for your career and for your medical education. So basically, if you think that you could benefit from having somebody working on your side with you like that, we're here.
Awesome. Beautifully said. And with that, we realized we're a little bit over our 1 hour mark, but are happy to answer any residual questions that we may have missed as we were chatting. Please, if a question that you had previously was not addressed, repost it in the chat. If not, we'll hang out here for 30 seconds to a minute, and we'll just hang out and see if there's any questions.
Okay, I'll mention too, while we're sitting here waiting, please feel free to fill out our kind of survey form that was just blasted into the chat there. We'd really appreciate you guys giving us some feedback in terms of how we can improve webinars like this, certain topics that you'd like to see in future webinars, things of that nature. It takes less time to answer the questions on there than it does to answer one single question in UWorld. So if you just have a moment, we'd really appreciate your feedback. It really helps us out a lot.
I'm not seeing any new questions, Joe. Anything that I missed?
No, I don't think so. It looks like everybody was asking their questions along the way when it comes to the content there. So I'll say from my end then that I really appreciate everybody showing up tonight. Thank you for the active participation. It always makes things more enjoyable, fun, and easy for me and Moses when you guys are kind of shouting answers back at us. So thanks for being so active and for following along with our conversation this evening. Really appreciate you guys coming out and working hard with us.
And I completely echo that. Best of luck with whatever exam is next on the docket for you. Really wishing you all the best. We're all in this together. All right, everyone.